So I think we'll get started. We still have a few that are joining us, but hopefully they will catch everything. So for those of you who don't know who I am, my name is Crystal Jacob. I am a supporter of the Lois Hole Hospital for Women Women's Society. I am also the co-chair of our development committee. The Lois Hole Hospital Women's Society is a group of women in all stages and ages of life who are passionate and committed to raising excellence in women's healthcare and women's healthcare initiatives. We raise important awareness and funds for a variety of initiatives within the community and for our Lois Hole Women's Hospital, which is the only all-women's hospital in our community. So we are super proud to support them. We host our Mind and Body Talks as an inclusive speaking series monthly, and this is to engage and stay connected with our community. So before we dive into tonight's session, I'm just going to go over a few housekeeping things with everyone. So tonight we are honored to have two amazing nurse practitioners, Susan Prendergast and Michelle Jeannotte. They will be joining us tonight. Our lecture will be discussing all things menopause. So what the typical symptoms are of menopause. We will go over the difference between perimenopause, menopause, and postmenopause. They will also touch on what can be done for symptom management and help guide you on a path to understanding the role of hormone replacement and lifestyle modifications that can support you and make you feel your best. This is certainly a safe place for all. We welcome all to this group, and we hope that you can all ask questions and we will answer them as best we can. So any and all questions are welcome during this session. At the end of the session, we are going to have our Q&A period. So if you do have questions, we ask that you put them in the chat, and I will definitely get to them all at the end of the session. As for Zoom, there are a couple options. So you have your gallery setting and you also have the speaker view. And tonight we recommend that you would use the speaker view and then just stay on mute if you can, just so we can all hear the presentation as best as possible. I just want to let you guys all know that these sessions are recorded. So if you don't want to be seen, I would keep your camera off. Otherwise, you may end up on YouTube tomorrow. What else do we have for housekeeping? I think that's about it for housekeeping. Like I said, any questions, definitely welcome. Just throw them in the chat box and we'll get to them. But before we get started, I just want to thank Alberta Blue Cross for their continuous support. They help support this series. They sponsored us last year and they have continued to sponsor us this year. So we're super grateful to have Blue Cross with us. So tonight, Diana Campbell is going to bring greetings from Blue Cross for us.
So I hope everyone can hear me. I'm notorious for the double mute. So hello and good evening. First, I wanted to thank you, Crystal, for the whole team over at the Lois Hole Women's Society for having me tonight. I'm so thrilled to see everyone here for another month of What the Health, and very excited for my first YouTube debut. So as a proud member of the Alberta Blue Cross team, I know, actually we probably all know that virtual fatigue is real, whether that be at work, school, or family. And I couldn't be more thankful that you took the time out of your day to be at this event. So while I know we're all here to learn more about perimenopause, menopause, and hormone replacement, I'm going to start the evening with a land acknowledgement. So I encourage each and everyone to take a moment, close your eyes, be present, and think about the words in this acknowledgement. Today and every day, we respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory, and that the City of Edmonton and us, the people here, are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada First Nations, such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We are taking this important moment here today to acknowledge all the many First Nations, Métis, and Inuit people who have called this area home since time immemorial. So now that we've all had a moment, I will pass the virtual microphone back to Crystal.
Okay, guys, I'm just over here talking to myself, having a time. Anyways, thank you so much, Diana. That was awesome. So I am actually going to throw this virtual speakerphone over to Brianna, and she is going to introduce our speakers for this evening.
Hi, everyone. I'm so happy with the number of people that are on this call. I'm really excited for everyone to hear this information. It's going to be fantastic. My name is Brianna Botsford. I'm a fellow supporter of the Lois Hole Hospital Women's Society, and I'm a member of the Development Committee. I have the honor of introducing our speakers to you this evening, Susan Prendergast and Michelle Jeannotte. Susan is the clinical director and nurse practitioner at Alethea Healthcare. Susan has been a registered nurse and nurse practitioner for over 20 years. During this time, she's helped thousands of patients to feel their best with customized wellness and healthcare plans. Susan has a unique background in that she has worked in a variety of specialty areas in women's health, as well as primary care. She has advanced knowledge in comprehensive hormonal evaluations, hormone replacement therapy, nutritional and exercise programs, and other approaches to disease management and prevention. She is committed to bringing the most current evidence to the care of her patients. And then we have Michelle Jeannotte. Michelle graduated with her master's in advanced nursing practice from Athabasca University in 2013. She graduated with distinction with a BSCN from the University of Alberta in 2007. She went back to earn her master's in part because as a nurse, she didn't want to merely take instructions from physicians, but rather wanted to work collaboratively with patients and doctors to come up with a plan of care. Currently, she is licensed as a family nurse practitioner. Michelle loves being a nurse because she loves helping people. She finds nursing to be an incredibly rewarding role because she gets to help patients through difficult times in their lives. Michelle currently works in primary care and dermatology. She specializes in medical and aesthetic dermatology, as well as BHRT, bioidentical hormone replacement therapy. Her previous roles include urgent care, home care, and cancer care. She also has experience as a bilingual French and English nursing instructor at the University of Alberta. Michelle has a great passion for community and international aid initiatives. She has traveled to countries like Ghana and Egypt to perform medical procedures and teach health professionals new skills. Closer to home, she volunteers each year for Santa's Anonymous, is the vice president of Prematernelle Bobinette, and sings with the Cocopelli choirs. She is married, oh, maybe she'll sing to us. She is married and has a 5-year-old son and a 2-year-old daughter. And she loves the outdoors when not working. She loves the outdoors, and when she's not working, you will find her stand-up paddleboarding in the summer and skiing in the winter. So welcome, Susan and Michelle. Thank you so much for joining us tonight. I'm so excited to learn from you.
Thank you so much, Brianna.
Yeah, thank you. I will not be singing. That's why I sing in a choir. There's a group of voices.
So what we're going to do to start is we're going to watch a quick video. So just give me 1 second while we switch our screens over. I always like to share this video with people when we're starting to talk about perimenopause and menopause because it's so true. Just give me a signal, Crystal, if you can't hear.
There's just one more store I'm not allowed to go into.
Oh,
Yes,
I can hear. I just want to mention one last thing to everyone, and that is that tonight we do have live transcript that you can see at the bottom. It's our first time using this. It's not 100% accurate. However, it seems to be working really well so far. And we're doing this on part as inclusivity, and I really hope it helps.
Hot. Is it hot in here?
No, I'm perfect.
Really?
Yeah.
In that turtleneck?
I'm actually a little chilly.
Maybe I'm coming down with something. Just,
Maybe it's perimenopause.
you think?
I don't know. Is it?
I don't know. Is it? No.
No.
I still wear a jean jacket.
Yeah.
I still drink out of a mason jar.
You're hot for no reason, so is it?
Is it?
Is it?
Maybe? Fuck. Have you read this? I don't know.
The rocket equation. It's a beautiful thing.
Gotta love it. I don't know what happened there, so just give me 1 sec and we'll see what's going on. It worked earlier.
No astronaut launched through space with their.
I can't remember. You can't remember. It's a whole book. How can you not remember reading the book? Unless it's perimenopause. Is it? No. Is it? I mean, it can't be. No, it can't. But is it? Is it? I don't know. I still get acne. I have a snowboard. It can't be. No. There's no way. No, it's not. Is it? Hey. Hi. Oh, those are super cute sunglasses. Are they? Yeah, they are really. Jesus. Wow, I don't even know why I did that. Sorry. Oh, is it perimenopause? No. Is it?
Is it perimenopause? I don't know. Do you have more underarm hair? My armpit hair got a lot thicker. Was that on my chin?
God. Is it perimenopause?
I don't know.
Well, you should know. You're my mother.
I think it is.
It is?
Is it?
I'm the baby of the family, though.
You are?
Am I?
Oh, sweetie.
Honey,
Have you talked to a doctor?
I can't sleep. I'm hot all the time. My moods are up and down. I burst into tears for absolutely no reason. Is it perimenopause?
Oh, I don't know. Is it?
What do you mean? You're my doctor.
Oh, it could be. There's not really much research. I mean, who really cares, right? But the one thing we do know is that it can last up to 10 years.
10 years?
Or more.
What?
Or less. I don't know what else to tell you.
I don't know. How about maybe you just tell me what's going on with my body? Anything? Is that too unreasonable a request?
Yes, it is. Definitely.
Okay, so we're just going to take a second to share our slides here and get into the presentation. Unfortunately, for some people, this video is that we just shared is quite real. A lot of women are not supported in exploring this topic with their friends, family members, care providers, and a lot of times also our concerns are brushed aside. So our purpose tonight is to provide information, help you to understand what might be going on with you, and to give you some answers to some of your most urgent questions. We're going to be sharing the presentation. Michelle is going to start us off, and I'll be doing the second half. So I'll hand over the mic to Michelle.
Yeah, thank you, Susan. That was a great video, and I just wanted to thank everyone for joining us tonight. I know it's a beautiful evening out, but this is a very important topic and we wanted to enlighten you guys about it. So what we're going to discuss tonight is we're going to discuss what exactly is menopause, what are the typical symptoms of perimenopause and menopause, and what are options for symptom management, as well as things that can help with long-term health and wellness. And we're going to tell you where you can find help. So to start the presentation off, we're going to add in a poll question here. So what does everyone think the average age of menopause is? And we'll have that pop up here in just a second. Oh, there we go. If you guys could answer, take a few minutes or a few seconds. Okay, I think everyone's had a chance. We can see the answers there now. Awesome. So there's a varied response there. So let's find out what the answer is. So what exactly is menopause? So the clinical definition of menopause is the absence of menses, which is your period, for 12 months. And we know this is a process. It's not one night you go to sleep, the next day you wake up and you're in menopause. It's definitely a transition. It includes the phases of premenopause, which is your average cycles before perimenopause, where everything can go wacky, menopause, where there's no cycles, and then the postmenopausal period. And for many women, this is a transition to a different way of living. About a third of a woman's life is spent in postmenopause. And I just wanted to add in a little tidbit here that we're not the only species that goes through menopause. There's actually whales that go through menopause as well. So the answer to the poll question here is normally symptoms of perimenopause occur between 40 and 58 years old, with the average age being between 50 and 52. And I think most of our viewers here answered the right answer. However, I do see a lot of patients in my practice that start to have symptoms much earlier than 40. So if you're experiencing symptoms earlier, that can be normal as well. So we know that there are some particular lifestyle choices and medical conditions that can hasten menopause or perimenopause and can make the symptoms worse. Smoking on average can cause menopause to come 2 years earlier. We know that obesity or low body mass, having no pregnancies, having type 2 diabetes, thyroid problems, and of course stress can all have an impact. And that's because our hormones are all intricately related and they rely on a complex feedback mechanism. So even a change in one hormone, it can trip everything up and it can cause the symptom as well as disease. So I think everyone can relate to looking at this graph back from, I remember doing this in biology and nursing school, but I wanted to review it because it is important. So basically, I don't know if can you guys see my cursor a little bit floating around? I'm pretty sure you probably can. Oh, perfect. Okay, Susan. So basically at the beginning of the cycle, the top is the ovarian part of the cycle. So you can see that FSH, the hormone, the follicle stimulating hormone, it recruits the follicles to recruit an egg for fertilization at the beginning of the cycle. That follicle, it produces estrogen, and when ovulation occurs, which is around day 14, but we know for a lot of women it can be earlier or later than this, that is when FSH and LH peaks and estrogen dips down. Now, when that egg is released, that follicle turns into the corpus luteum, and what happens is that corpus luteum, it secretes progesterone, which in turn thickens the uterine lining, which is the bottom of the graph there. The reason why the uterine lining is thickened is to prepare for a possible pregnancy if that egg is implanted, is fertilized. If there's no fertilization, if nothing occurs, the corpus luteum turns into the corpus albicans and everything starts over. And that occurs about in a 20-day period or 28-day period. But know that there are variants in that cycle. Awesome. So this is kind of just going over what we just talked about, but I just wanted to point out that the main important hormones to talk about are FSH, estrogen, LH, and progesterone. All right, perfect. So estrogen has many, many functions in women's bodies, and men also have estrogen in their body, but we're going to be focusing on women here today. So for the brain, you can see from the video, it has functions for memory. So estrogen helps to prevent memory loss. It helps to maintain your body temperature. In the breasts, it helps to stimulate puberty. It prepares your milk glands. Heart and liver, it has a big function. It regulates cholesterol production. It reduces plaque buildup in the arteries. In your ovaries, it has a lot of different functions in our reproductive system, but ovaries, it stimulates maturation of the ovaries and it kickstarts the menstrual cycle. In the uterus, it stimulates maturation of the uterus and prepares the uterus for fetal nourishment. In the vagina, it stimulates maturation of the vagina, but it also maintains vaginal lubrication and it thickens the vaginal wall. and the vaginal lining, sorry, and it also has a big importance for our bones. So it prevents bone mineral density loss. So we're going to talk about estrogen and progesterone. So these are two opposing hormones. Estrogen has, when it builds up the uterine lining, progesterone maintains the uterine lining or helps to secrete it. Estrogen increases your body fat. So as women, estrogen is what helps to bind fat in our buttocks, in our hips, our stomach, our breasts. So progesterone helps us to use that fat for energy. Estrogen is what causes in some women migraine headaches and depression. And progesterone has an antidepressant effect. Estrogen interferes with thyroid hormone and progesterone facilitates thyroid hormone action. Estrogen increases your blood clotting and progesterone can help with that blood clotting. Estrogen decreases libido or your sex drive and progesterone can restore it. Estrogen impairs blood sugar and progesterone regulates blood sugar. Importantly, estrogen increases your risk of endometrial cancer and progesterone protects against endometrial cancer. So all women that have a uterus needs to be, if they're taking estrogen, needs to be taking progesterone as well. Estrogen also can increase the risk of breast cancer and there's a possible prevention of breast cancer with progesterone. So with all of that, I like to consider progesterone as your calming hormone. It helps to, it's an anti-anxiety hormone. It helps to regulate your blood sugar. It balances out your estrogen. All right, so before we get into the slide, we're going to add an extra poll question here. So the poll question will be, how many people here have a regular menstrual cycle? You can take a minute to answer. Okay, that was a pretty quick one, so I think we might have an answer already, so we can show the answer there. Oh, it's pretty even across the board there, so very interesting. And no cycle we were discussing previously could be due to an IUD, or it could be that we're in menopause. So what happens as the cycle changes? So after the age of 40 or earlier, as we discussed, the ovaries are less responsive to FSH. FSH doesn't want to give up, so it tries to bribe the ovaries into responding. And initially, estrogen levels do increase, but they do decrease as fewer follicles are recruited. Progesterone levels fluctuate as the corpus luteum produces variance amounts, depending if ovulation even has occurred. And over time, fewer and fewer follicles are recruited until eventually no follicles at all are developed. And then FSH and LH are permanently elevated. So initially, progesterone drops more significantly than estrogen because estrogen is more unstable and volatile, but eventually at the end, both hormones are stable and low. And before we get to our next slide, we're going to ask another poll question. So we have a couple, we would like you guys to see if you know the symptoms of perimenopause. I know the video did show some of them, so if you could take a second to answer the question. I think everyone's going to get this one right. So let's see the answer. Yes, almost everyone. Awesome. All right, so let's move on to the next slide there. So typical symptoms of perimenopause. So I will share my personal experience here, but I always like to say that my patients are the experts in this because I have experienced a few perimenopausal symptoms, but a lot of my patients have experienced almost all of these. So patients are always the expert when it comes to this, but a lot of patients report that they get hot flushes, which come on suddenly and they last about 4 or 5 minutes, or night sweats. A lot of people get irritation or they're quick to anger. They have anxiety, and we'll get into that a little bit later as well as why this happens. There's brain fog, there's difficulty concentrating. A lot of women say they have a hard time sleeping or they have a hard time staying asleep. Weight gain is one that a lot of my patients come to me for because they're eating well, they're exercising, they have been a stable weight their whole life, and they just don't understand why they're gaining weight in this point of time. There's changes in your cycle. So most women will go a few months without having a cycle, and then we'll get one really heavy period. But some women will just have really some small cycles here and there, or it can be anything really with the cycles. Vaginal dryness is one that I've personally experienced. So about a year ago, I was having symptoms of what I thought was a yeast infection, a typical yeast infection. I treated it. It did not go away. So I saw my doctor. She did all the tests that the doctors does, and everything came back normal. And I was like, oh, really? What do you think this is then? And she's like, I think you're having some perimenopausal symptoms. And I'm 36, but at the time I was 35, and I was like, I don't know. I don't know if she's right. But she prescribed some vaginal estrogen for me, and I tried it. And honestly, the next morning when I woke up, my symptoms were gone. So that's the power of hormones, as well as how well they can help control symptoms. So know that you're not alone if this happens. And a lot of our patients also report a loss of libido or just like a lack of interest in sex. Awesome. So we have a few different graphs here of kind of show what goes on. In the first graph, that's the normal cycle, or the normal menstrual cycle we talked about in the first slide. Now, this is a slide that can happen in perimenopause. So almost every day can be a peak and a valley. It can be anything goes in a 28-day cycle. In the graph on the bottom here, you can see the fluctuation of hormones. Estrogen, progesterone, doesn't really know what it wants to do. And then eventually at menopause, estrogen and progesterone are leveled out and low, and the FSH and the LH are elevated. So this is a very similar graph, but I just wanted to point out a few things on the slide here. So definitely when estrogen and progesterone are decreased, there's more bone loss. So I know that Susan will discuss how important it is for osteoporosis prevention, as well as when these hormone changes occur, there's a decrease in cognitive function. And there's actually some studies that show that estrogen can help with prevention of dementias as well as Alzheimer's disease. So this is a very, very important topic. It's not just to help with symptoms, it can help with health in general. So before we get into sleep, we have another poll question here. So we just wanted to know how many of our viewers here get on average 7 hours of sleep a night. Pretty quick yes, no question. So I think we can get the answers here. Okay, so more people are not getting 7 hours. All right. And that goes part and parcel with what we kind of have here for our statistics. So more than half of perimenopausal women, about 56%, sleep less than 7 hours a night. And why? Well, I can think of a few things: getting up to pee, having a hot flash, having kids that wake you up in the middle of the night, having anxiety, having poor sleep hygiene, being on our phones until 10 o'clock at night and then expecting to go to sleep right away. But there's definitely a hormonal component to sleep as well. So we know progesterone increases the production of GABA, which is a neurotransmitter that influences sleep. The metabolism of progesterone to allopregnanolone causes calming and relaxation. And during this perimenopause-menopause period, there's lower levels of progesterone, which decreases both the GABA and the allopregnanolone, which causes some people to be up all night. So you can see in this graph, there's a few different changes that women report depending on what stage they are in the perimenopausal transition. So in the early menopausal transition, most women find that they're waking several times a night. Later, they're still finding they're waking several times a night. And postmenopausally, most women are saying they're having difficulty falling asleep. So, or having a combination of everything. So we saw from the video at the beginning as well that it absolutely can affect our mood. So it's known that fluctuating levels of estradiol or estrogen, it increases vasomotor symptoms, which can correlate to anxiety in perimenopause. So intriguingly, there is also a link between hot flushes and panic attacks. So when you're having a hot flush, you're having possibly sweating, heart palpitations, hard time breathing, nausea, and this can definitely be linked to a panic attack. And it's thought that this might be brought on by lower than required levels of progesterone, increasing the stress response or prolonging the stress response. Estrogen also has effects on serotonin, norepinephrine, dopamine, and melatonin, which are neurotransmitters, and it can either be positive or negative here. So that's why it's so important that there needs to be a balance between estrogen and progesterone. And this is also why sometimes medications called SSRIs or SNRIs are used to treat some menopausal symptoms. So this is the point in the presentation where Susan's going to take over, and she is going to discuss why it is so important. I mean, we talked a little bit about how quality of life is affected by all of these things, but Susan's going to get in more into the nitty-gritty of everything.
Thanks very much, Michelle. So a lot of the patients that we see in our practices have a lot of times explored getting help with their symptoms and perhaps have been told that, oh, this is just part of being a woman, or this is just normal. Everything looks normal. Everything must be fine. The thing about being a woman in your perimenopausal years is that perimenopause is probably one of the most challenging times in your life. A lot of women find their symptoms actually start to resolve post-menopause. At least then they're not having a very abnormal cycle that they also have to deal with on top of all their symptoms. The problem with this attitude, though, of, oh, it's normal, you know, you'll feel better in a couple of years, is that we now know that going through menopause and not having your own bodies or some sort of external source of estrogen, progesterone, testosterone, and some other hormones can actually put you at increased risk of disease. So certainly we've known for a long time that estrogen plays a significant role in maintaining bone. It interrupts the degradation of bone as we age. So it's important to maintaining our bone strength and stability. More recently, though, there's been several extremely important studies that have demonstrated the importance of estrogen to cardiovascular disease prevention. And we'll talk a little bit about that as we move forward. Certainly as well, there's also evidence that estrogen, progesterone, and testosterone all play a role in mood, sleep, and memory, and as well can have a significant impact on the vaginal flora, vaginal canal, vaginal tone, urethral and bladder health as well. So why would we treat? We would treat for many reasons, symptoms being one, but also for disease prevention. And so for people who are at higher risk of any of these situations, we want to be thinking about hormone replacement. Hormone replacement has been a very, very controversial topic for so many years, and unfortunately that hasn't changed in the recent time. I believe it's partly because a lot of our professionals are still stuck in understanding HRT or hormone replacement therapy from the 90s. There was several studies, or two big studies that were done in the 90s that were stopped because of the negative things that were happening to the women that were involved in the studies. The studies were originally started to identify the outcomes that women would potentially see from introducing hormone replacement for menopausal symptoms. What ended up happening is that these symptoms were, these women were not necessarily the right people to be involved in the trials. And so we'll talk a little bit about how that has changed HRT offerings in our time now. Because of these trials, hormone replacement therapy has gotten a bad rap. And so a lot of your healthcare professionals and even you or your family members may have been told to stay away from hormones. And we're actually now in a place where we've got a significant amount of literature just to disprove what was understood from the past. Many people are still afraid of prescribing hormone replacement. They perhaps don't know how to assess the appropriateness of these therapies. And obviously, it also takes quite a bit of time in order for you to get that kind of a support from the professionals. So certainly understanding that as we're moving forward, we're basing our decisions on new and excellent research. So what happened with the trials that were done in the 90s? This blue table was taken from a more recent review of the Women's Health Initiative. But basically what happened is these women who were involved in the studies were taking conjugated equine estrogens, which is basically horse urine in a tablet form, and progestins, which is again, a synthetic progesterone. And the study was seeing that there was a higher outcome of heart attacks and strokes, as well as thromboembolic events and breast cancers for the group that were using estrogen unopposed. So as Michelle already noted, it's very important for women to always be on progesterone to balance any estrogen. So one of the arms in the study had women on unopposed estrogen, and those women were experiencing higher events of breast cancer. What the study also showed was that women were getting relief from symptoms, and there was a decrease in hip fractures and colon cancer. So there was good things that happened and then some terrible things. The reasons why the trials were stopped was because women were having heart attacks and strokes. And so I'm going to spend a few minutes talking about this, because this is really important for you to understand why people are afraid to give you hormones and why you don't need to be afraid of them. So basically what happened with the trials is that the women that were involved in the trials were, most of them, the vast majority of the women were older. So they had been post-menopause for more than 10 years. So they had had no estrogen in their system for 10 years. What happens when we don't have estrogen in our bodies is that the plaque and the cholesterol that we have in our blood vessels thickens and hardens, and it calcifies. So when you then give women estrogen does a great job of going in and cleaning out your vessels and chipping it away. So for a woman to have estrogen introduced in her 60s and 70s, which is what happened with these old trials, it was like setting them up for failure, because the estrogen is going to go in and it's going to clean out all that hard plaque. So the women that were in the trials were older, and they were post-menopause. Vast majority of them were in their 70s, so 10 plus years post-menopause. Many of them also had comorbid disease or comorbid risks. So many of them were smokers. Some of them already had cardiovascular disease. So not only were they 10 years plus post-menopause, they were also living with cardiovascular disease. So again, at higher risk of having a heart attack or stroke. And then we're giving them this wonderful estrogen that does a great job of cleaning out their vessels. And then the other thing that I had mentioned before is that some of them were put on estrogen without the opposing or balancing hormone of progesterone. So when the researchers since that time have gone back and looked at these trials, there's been several comments that the trials were poor. They were poorly designed trials. The participants were not appropriate. And certainly the hormones that were being used were not good either. And we've moved away from those hormones, and we now have much better understanding of when is the right time to introduce particularly estrogen into our lives. There's been several trials since that time, and I'm not going to go through this in great detail. But certainly if you wanted to review these down the road, you are welcome to. They're available on some of them even through a Google search. Several of the trials have been replicated with different medications, so different therapies, since the WHI and HERS trials in the 90s. And it's been demonstrated that women who have been offered and started to take estrogen or estradiol in particular prior to 10 years past their menopausal transition, they will see a lower risk of coronary heart disease and death from any cardiovascular cause than women who are on a placebo. So it does actually benefit you to be on estrogen from a cardiovascular perspective. You do not see the same amount of decrease in cardiovascular disease if you introduce the estrogen later. So if it's introduced too late, it's not going to necessarily do as good of a job. Certainly, it's still safe to do that within a certain time frame. Again, all of these other trials are all looking at different outcomes from introducing conjugated estrogen, or sorry, not conjugated estrogens, that's the bad stuff, estradiol and progesterone. Certainly we see women will report better symptom control, better bone density, bone maintenance, better sexual function, better mental health. And there's, like Michelle had said, there's a couple of trials ongoing at this point in time looking at the role of estrogen, progesterone, testosterone, and pregnenolone specific to memory and dementia. So very, very important hormones to disease prevention as well as symptom control. One of the other things that we continually see in the newer literature is the identification of the newer products. So we're looking at products that contain 17-beta estradiol as the estrogen of choice. Unfortunately, the estrogen that was used in those old trials in the 90s is actually still on the market. So we want people to understand that they, if they are going to be using estrogen, that they're using the right products, not Premarin, but 17-beta estradiol products. The Premarin is the stuff that was, like I said, used in the older trials. And there has been a bit of discussion in our world, the hormone world, about the product shouldn't even be on the market at this point. So just be very, very cautious about what sorts of estrogen you're actually getting from your provider. So basically the difference from the 90s to now is that we understand women should be starting hormone replacement for symptom control whenever they need it. But estrogen in particular should be started as soon as a woman goes through their menopausal transition, using 17-beta estradiol or bioidentical products versus the conjugated estrogens, which are the stuff that it's just far too unlike our own body's estrogen. And micronized progesterone versus progestins. So the micronized progesterone is considered more bioidentical. So the closer you are to your menopausal transition, the safer estrogen is, and the better actually outcomes you'll get over the long term because it will reduce your risk of cardiovascular events. There's also quite a bit of discussion in our, in the hormone world about bioidentical hormone replacement therapy. And I believe that some of the misinformation is coming from the fact that originally when bioidentical hormones came onto the market, people had this understanding that they were made from plants in someone's backyard and given to people, and that's actually not the case at all. Any of the hormone replacement that you would be receiving from a regulated healthcare professional like Michelle or myself, and there's a couple of other providers in the city, are pharmaceutical grade, compounded generally, can be compounded products, and they are approved by Health Canada. It's not like we're giving you stuff from our garden. But I think it did get a bad rap because at one point there was some discussion in one of the original publications around BHRT about the fact that some of the bioidentical products actually do start with plants, yams in particular. But the beauty of the bioidentical hormone replacement therapies or any of the HRT products that are on the market right now is that they actually are identical to our own biology. So they are able to mimic the action of your own hormones as well as anything could. And there has also been some discussion about moving away from the term bioidentical and just using hormone replacement, because really what we are doing, regardless of whether we're compounding it for you, and we'll talk about that in a bit, or prescribing you a product that's coming out of a bottle from the pharmacy, is that it's pharmaceutical grade. It's all bioidentical with the exception of Premarin. The products are made for you and they can be dosed for you if they're compounded, which is one of the reasons why a lot of people still use the term bioidentical, because we can give you a dose that's specific for you and make it up into a product that's more particular for your needs. So if you have a gluten intolerance, or if you're allergic to dairy, or if you can't eat rice, there's a way for us to get around all of those sensitivities. So again, this difference between the bioidentical and the synthetic, there's less difference nowadays than there was 20 years ago, certainly. Most of the products that are on the market right now are the best products you could ever have had at this point. So we use the bioidentical hormone replacement or hormone replacement therapy to minimize side effects, to improve quality of life, but also to decrease the risk of bone loss, cardiovascular disease, changes to our uro and reproductive system health, and mental health and memory. I think one of the biggest problems for women is to understand when they should be considering talking about treatment. We have had, like Michelle, many women that come to us in their 30s being told that they're too young to be going through what people termed menopause, but it's actually perimenopause, and that's actually not true. I started my perimenopausal journey at 30, and thankfully, because of hormones, I'm only just now going through menopause. Certainly, if I hadn't have gotten help, I would have probably not be married, because the mood changes, the sleep, and all of the other stuff that was happening to me was significantly impacted my life, which is why I do what I do. So if you are younger and you're experiencing things like night sweats, weight changes, mood changes, anxieties, you know, your period is not the same, it's different, heavier, less, lighter, whatever, it is absolutely possible that you could be going through perimenopause. And if you are, then there's treatments available, and we'll talk about what that would look like. What our typical patient looks like is a woman who's in her 40s. She's got teenage children, a busy career. She may be looking after older parents. She may have a partner. Is experiencing night sweats that tend to be more around her cycle. So maybe a week before she has her period, she'll have night sweats. Significant fatigue. She feels as though she could have a nap in the afternoon and wakes up feeling like she's kind of dragging her butt out of bed every morning. Maybe experiencing exercise fatigue. So where she would be able to work out 3-4 times a week, now it's just really difficult for her to do that. Her cycles are changing. They're closer together, so shorter and much heavier, to the point where, you know, she's losing her iron. Her iron and her iron status is at risk. She's experiencing vaginal dryness, anxiety, what we call ragey. So she flies off the handle a lot more quickly than what she would have normally. And she's waking up 3 to 4 times a night, typically between 2 and 5 a.m. She's already done all the work, perhaps, that she needs to, but no one will listen to her. And this is the typical person that we will see in our clinic. So there's lots of options for you, regardless of your age. Certainly, we would want to be offering you opportunity to be treated for hormone deficiencies, whether it be with the typical hormones we talked about today, estrogen, progesterone. We also have options to treat with testosterone. But we also look at the other hormones that are part of the feedback loop, including thyroid and adrenal. With hormone replacement, we would replace the hormones with those that are identical to the hormones produced naturally within the human body. These bioidentical products are more easily metabolized. Because they're bioidenticals, there's minimal side effects. And especially if they're prescribed and monitored appropriately, your side effects would be almost non-existent. Like I mentioned before, we can also compound hormones, whether you get your prescriptions from your primary care provider or a person who does hormone replacement therapy as part of their specialty. We can prescribe the products that are, like I said, in a bottle at the pharmacy that come in specific doses, or they can be compounded for you. The care that we would provide for you as a perimenopausal, menopausal, or postmenopausal woman doesn't just involve hormone replacement. Certainly, if you were meeting up with someone the first time, we would do a full comprehensive history, get a really good understanding of who you are and what's happened to you as far as your reproductive life and your health history. Sometimes we will do physical examination, very little time we do that now, especially with COVID. A lot of our appointments are now virtual. But if we did need to, that would be something that we could possibly look at, especially if women are experiencing lower abdominal pain with their cycles, or they're having breast lumps and that sort of thing, then that certainly should be part of your care. Where we would start with the vast majority of our patients after the history is doing blood work. And blood work is really important as a baseline for deciding how to move forward. So if a person is early in their process, so they're perimenopausal and experiencing symptoms of sleep disturbance, temperature dysregulation, anxiety, Michelle and I already would know that most likely we're going to be giving you progesterone. Progesterone is very safe. We prescribe progesterone for pregnant women. That's how safe it is. And 9 times out of 10, that's the first therapy that you would be put on. My experience with progesterone was literally that it changed my life. I was able to sleep through the night. I wasn't as ragey and anxious as I had been for the few years previous, and it allowed my cycle to stabilize. So we would be using, depending on what's happening with you, different doses of progesterone orally or by cream that would help you with some of those symptoms. If you're already through menopause, so you're not having a cycle because you've either had your ovaries and your uterus removed surgically, or you're older than that perimenopausal phase, you're past that phase, then we would also talk to you about potentially introducing estrogen. And if you're going on estrogen, you're automatically on progesterone. So again, the blood work is going to help us decide where you're at in that transition and what things need to be or could be optimized. And we use the word optimized because it's not necessarily about replacing to a particular range. We want you to be feeling great, and our goal is to get you optimized so that your body not only can function and prevent the disease processes that we want it to prevent, but also that you're feeling amazing. I will admit to you that some of the guidelines that your primary care provider would work within, or even some of your specialists, we don't look at those the same. So our blood work ranges are a little bit different, and it makes us perhaps a little bit able to look beyond kind of the strict regimen that others do. And then, of course, obviously, our approaches would always be to work on a plan with you. So if you're not interested in doing some of the things that we would suggest, then that's up to you. It's just a matter of us coming up with a plan that's going to work for you. We always also talk about lifestyle. You're going to get the best results if you can do all the things that we've put on this slide. So smoking is something that we would want to try to support you in reducing and eventually discontinuing. There's very few people that I have come across actually that are smokers, but if you are smoking, then we would be introducing the hormones much more slowly, because as I mentioned already, a person that has a cardiovascular risk already would be at higher risk for a cardiovascular event. We do hope our patients will be eating clean. So using the Mediterranean diet approach, or high vegetable, low carb, and low red meat kind of approach. But certainly there's lots of different approaches to diet that can work for different people. A low alcohol intake, ideally no alcohol intake, using your body, getting moving, using excellent stress management if possible, and if not, then we would explore that with you to ensure that you're going to get the best out of the products that you're using. And then one of the other key things, and Michelle already mentioned it, is excellent sleep hygiene. So a lot of our patients, this is one of the things that they have to work on the most, is getting to bed at the right time with no TV, no phone, no iPad, a good old book, an actual book, no coffee, no tea, et cetera, et cetera. So we do a lot of this work as part of our care. And actually with most nurse practitioners, this is part of the care that you would get anyways if you were seeing one of us. Your options would depend on what you need. So if you're having symptoms of sleep disturbance, night sweats, mood changes, anxiety, we might, and you're young, so you're in perimenopause, we would use micronized progesterone. Possibly, if you're fatigued, we might look at thyroid. We might consider introducing some testosterone for low sex drive. It really does help also with energy and mood. If you're a person who's already post-menopause, then we would introduce estradiol. And estradiol is amazing, like I said, for bones and cardiovascular health, but it's also fantastic for hot flashes and night sweats, so temperature regulation, energy. It's kind of your energy hormone, whereas progesterone is your relax hormone. We also use other therapies. Not all of the hormones that we can introduce are listed on the slides, depending on your needs. So again, if there's a symptom that you're experiencing and it's a hormonal imbalance, then there's usually a hormonal replacement option for you. In my practice, I do a lot of teaching around supplements and diet and exercise. I believe Michelle probably does as well. And so for sleep, even if your progesterone isn't quite enough, then we would talk about some other options. But supplements are a really, really big, important piece for you getting the best out of your body. All right, there's probably lots and lots of questions, and I realize it's already 8. So I'm going to just put our where to get help slides up. Both Michelle and I work at separate places. So to get hold of her, her info is here. She works at Lucere, and I have my own clinic at Alethea. So you're certainly welcome to reach out to us. There's other providers in the city too that do this sort of work, and we'd be really happy to answer questions at this time. All right, Crystal, I'm hanging it over.
Okay, thank you so much, Michelle and Susan. That was super informative, and I'm really excited to get into the questions because we have so many of them. Okay, so I'm gonna start at the top here, so I gotta go back. Give me a sec. Okay, I love questions like this because I get them all the time as well. How do you know when your cycle changes when you've had a hysterectomy?
Do you want me to go first, Michelle? We were going to alternate questions, so I'll start. So the slide that I showed of that blood work form, that's key. Even in what we always want to start with blood work. And so what we would look for is that period of time when your FSH and your LH have started to rise. That's a sign of that you're starting to go towards menopause or you're post-menopause. So the slide where the FSH and LH was going up tells us that there's less follicles that are being recruited every month, and your body's having to work much harder to get those eggs ready, or there's none left at all. And it goes up and up and up every month. So once it hits a certain point, we can safely say that you're post-menopause. And we would then be safe to introduce estrogen. It's an excellent question.
Awesome. Yeah, that's great. Okay, and so our next question is, when is it too late to have good results with hormone replacement therapy?
That's a very good question, and I would say it's never too late. We don't, as Susan discussed in her presentation, we don't tend to add in hormone like estrogen if it's much past menopause, but it's never too late to have a discussion about other things that we can do for symptom management or even prevention of disease. So it's never too late to come in to talk to either myself or Susan about what can be done, as well as to get some blood work done to see where you're at, right? To see where things are looking and how we can make changes.
Excellent. So you can help everyone. I love that. The next question is prometrium the same as progesterone?
That's an excellent question. So prometrium is micronized progesterone. And for some people, prometrium is a great product. Why I, in particular, don't necessarily always prescribe it is because when we do a compounded version of micronized progesterone, we can do a slow release, which allows women to get the benefit of that progesterone throughout the whole night and into the next day. So it helps to keep them asleep. Whereas the prometrium is an immediate release product. So it helps them to get to sleep, but doesn't necessarily allow them to maintain that throughout the night and then get the benefits the next day. So you get a little bit longer effect when you do the compounded slow release product. But again, prometrium is a micronized progesterone.
Awesome. Okay, that's great. Okay, so our next question is, once you start taking both progesterone and estrogen, should the doses be increased ever? And how do we know when we could stop?
That is another very good question. So we take a peek at people's labs. So we start them on a lower dose and we absolutely increase based on blood work. So it's never a one-time blood work. We repeat blood work about every 3 to 6 months, and we adjust the dose based on the person's hormones. So it's very, very individualized. We don't tend to have people stop. I mean, as Susan explained, she has seen that there's not very many side effects. The benefits continue until, I usually say, forever. So we keep people on hormones for long term. I know some of my patients have gone off of the hormones just to see what it would do, and their symptoms all came back and they were like, oh, I guess these things are working. So we keep people on it for long term.
Great, thanks, Michelle. Next question, and we'll go to Susan. So what is the safety data for BHRT?
That's a little bit of a hard question because it's safe. As far as, maybe I don't fully understand the question, but it's medical grade where as long as it's dosed appropriately, it's been studied. We know the doses, we know how to manage it. I'm maybe not understanding the question well enough to answer it exactly what the person's after. Certainly, if you're thinking about is bioidentical versus Premarin as safe, well, I hope that that's clear. It's safer. So yeah, I think I'll stop because I don't want to confuse the other people in the room. And maybe that person could ask a different question because I'm happy to explain.
Absolutely. And I'm just going to get you to follow up on this one, Susan, just because it is the same person asking. HRT prescribed by physicians is bioidentical as well, right?
It can be. It just honestly depends on what products they're using. So if it's conjugated estrogen or Premarin, then no, that's not bioidentical. That's the stuff that was used in the Y trial and the HERS trial. But if your doctor is prescribing, or your physician, is prescribing a prometrium, So that's micronized progesterone, and estrase, which is 17 beta estradiol, that's estrogen and progesterone, then that would be considered bioidentical. We could have an argument about whether it truly is because they're made in a synthetic lab in a big lab versus compounded, blah, 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 but yes. Now, there's other products out there like patches and gels that are using some of the bioidentical, so 17 beta estradiol and micronized progesterone, but there's so many other products in that product that it's not considered bioidentical. Does that make sense? Because the filler and the delivery mechanism is not, it's considered extremely pharmaceutical.
Perfect. Thank you for the clarification. Okay, so this one's a little bit of a long one, but it's great. It says, thanks for the great review. I am 55 and took estradiol and progesterone for 18 months for hot flashes. When the progesterone prescription ran out in January, I thought I'd try and see how to do without them. The hot flashes have returned, but not quite as bad. Trying to decide if I should go back on them. What do you suggest?
I suggest that this person come in and see a nurse practitioner to have her hormone levels checked, and then we can adjust them. But absolutely, we could start her back on hormones. We just need to know where she's at and then make a plan from there.
So basically, if it makes them feel better, stay on it. Is that what we're getting at?
Mm-hmm.
Perfect. Love that. Okay. Do you recommend stopping HRT at some age?
I think this was kind of mentioned before. I don't ever recommend people stopping it. And from my perspective, the reason why is because as an NP, I'm really concerned about people's cardiovascular health and their bone health, and now also their memory. So certainly I would want people to stay on it as long as it's beneficial to them for as long as they wish. So I don't recommend people stopping it. Now, there are situations where people will stop. So I have a couple patients who, once they retired, they weren't able to afford the products because if they've chosen to use the compounded, they're not covered. So we might want to switch them to a different product. And if that's not covered, then they might decide that they can't afford it. And so they might decide to stop the therapies at that point. But it's so individual as to whether you want to stay on it, go off it. It's something that you would just talk with your provider about and get a plan in place, because also going cold turkey isn't always the best either.
Perfect. Thanks, Susan. Okay, next question. How do you manage patients that develop abnormal uterine bleeding and are on progesterone only?
Awesome. Another really, really wonderful question. So we would take a peek. So initially we would order an ultrasound to see what's going on. If things are looking all right, we would definitely take a peek at the blood work and see what else is going on. And then we would adjust the hormones based on that. Sometimes the ultrasound will show like a thickened uterine lining, and we'll have to refer on for that. So I don't believe that Susan managed that in her clinic. I wouldn't either. We would refer on to specialty clinic to manage that. But we would for sure order an ultrasound and see what's going on with that uterine lining. I don't know if Susan wants to add anything else there.
Sorry, we just lost our slides.
Yeah, I'm like, what just
I don't know what
happened?
happened there. Anyways, okay, we don't need to have that up, I guess. No, I think the only other thing I would say is that there is a rule for using an IUD in that situation if the uterus is healthy and it's really just a matter of that volatility of the estrogens causing those really, really heavy cycles and that very abnormal bleeding, whether it's menorrhagia or metrorrhagia, so bleeding throughout the cycle or really heavy bleeding when you have your cycle. An IUD is an awesome, awesome option. Or we maximize our progesterone doses. So we take a lot orally, maybe add in cream or a troche, which is a sublingual lozenge. There's so many options.
Excellent, thank you. Okay, next question. Are there natural supplements in care with respect to perimenopause?
I think this was for me. Sorry, Michelle, I wasn't sure. I'm not sure, again, if I'm understanding the question 100%, so I apologize if I don't get this right. What we sometimes will suggest alongside bioidentical hormone replacement therapy or BHRT is lifestyle changes, because a lot of people do benefit from direction around diet. So symptoms of perimenopause, like night sweats in particular, tend to be worse in people who drink alcohol and have carbohydrates late in the day. So sometimes we'll work with our patients to do intermittent fasting, or change their diet or their alcohol intake to lower the symptom of night sweats, for example, without using a hormone. Like I said, also we do suggest supplements that can benefit you as far as energy goes. So if you have an adrenal situation that your body's looking tired, or you're making too much cortisol or something like that, then we could work with you to change your diet, your exercise, your sleep, and use some supplements to address that. So yes, there's lots of, more natural, I guess, approaches. Not that BHRT is considered a more natural approach. But if you're looking for no medical intervention whatsoever, then yes, certainly there's also huge value to working with naturopathy if you're preferring that route.
Absolutely. Thanks, Susan. Our next question is the services within the clinic covered by Alberta Health?
That's a very good question. So basically, nurse practitioners are not able to be covered by Alberta Healthcare Services for the visit. So we do charge, Susan and I do charge for our visits. However, your blood work is covered under Alberta Healthcare. So when you go to the lab, you're not being charged for that. And medications are covered by your private health insurance plan. So depending on what coverage you have.
Perfect. And then maybe Michelle will get you to answer this one as well. Can we book appointments with nurse practitioners, and where do we start?
Yes, there's nurse practitioners. Well, you can book with myself or Susan at any point. I'm sure you could do a Google search and see who else is doing it in the city as well. But there's more and more nurse practitioners all around the city that are in private practice that are doing hormone replacement.
Absolutely. Okay. I am 43 in full medical menopause due to ovarian CA. Is it too late to look into hormone options 18 months out of treatment? Also, any natural options for night sweats?
So what we've done in the past with women who have experienced breast cancer, uterine or ovarian cancer is work with your oncologist to explore options as far as hormone replacement goes. So that's a very, very individual question. What was the second part of the question? Sorry.
Natural options for night sweats.
Oh, so the night sweats for sure. The couple of things that I mentioned before. So if you've already done kind of all that lifestyle stuff, then the next step would be looking at potentially introducing progesterone, testosterone, estrogen. It really just depends on what your particular oncologist is in agreement with. And I know I probably speak with for Michelle here as well. Post-cancer treatment, post-cancer experience is one of the toughest times for women, because most of those treatments put women into menopause, whether it's an ovarian cancer or a breast cancer and you've had to go through chemo. And a lot of times the symptoms are experienced worse than they would have been if you hadn't had that experience. So certainly we'd be willing to look at what the options would be for you as alongside your specialist. Cancer is a tough one.
Thank you. Yeah, I think as nurse practitioners, we are used to being very involved with all aspects of the medical field, and just having those relationships with the specialist will definitely help in client care. So if you, whoever asked that question in particular, would like to connect with one of the NPs, I can definitely speak on behalf of NPs that we're always looking to work alongside everyone who's a part of your medical health. Okay, so the next question is a good one. There's two and they're very similar, so I'm going to read them both. And I've heard this question a lot. So I have an IUD and I've had it for a number of years. How do I know without having a period if I am approaching peri/menopause? And then the next question is, What if I have a Mirena IUD? My doctor said I can keep it until after menopause, but I'm still getting hormones. How do I know if I'm in or done menopause?
That's another very good question. So Mirena IUDs, they do not secrete hormones systemically. They just secrete hormones into the uterus. So we're absolutely still able to do blood work on there and we can see what's going on. So as Susan mentioned before, we would do blood tests to see if these people were in menopause. It's harder to tell if they're in perimenopause, but if they're starting to experience symptoms, then we just say, yes, you're in perimenopause if you're having symptoms. So definitely it would be doing blood work. And so we can absolutely tell it's not just based on the period, it's based on the blood work.
Fantastic. I have a family history of estrogen positive breast cancer, but I'm also having several symptoms of perimenopause. Would her still be recommended, would HRT, not her, still be recommended with this history?
Unfortunately, in Edmonton, with any of the oncologists here, no. Especially with receptor positive, we don't recommend HRT. So looking at other options around the use of an SSRI, an SNRI for hot flushes, night sweats, some of the supplements, diet, lifestyle, etc., can help. Like I mentioned before, I do acknowledge that a lot of women like yourself would struggle more severely sometimes with the symptoms post-therapy. So looking out for other people who can provide some support to you. I do have a naturopath that I work a lot with, share patients with. So if you're looking for somebody like that can help you with some symptoms, certainly naturopathy would be a great option.
Awesome. What are your thoughts on using Vagifem for frequency and urgency of urination?
I guess it's my turn. So I do use Vagifem a lot with my patients. Vagifem works very, very well for those symptoms as well as vaginal dryness. And it doesn't only need to be the Vagifem. I also use a product called E-string, which is a ring that's inserted that's left in for a longer period, almost like a Nuva ring for birth control. So yes, wonderful product.
I agree. Okay, I have been on Synthroid for years, but am now in perimenopause and it's going wonky. What's going on?
Oh, it's interesting that you got me to answer your question. So thyroid is a love of mine. I do a lot of work with patients who live with hypothyroidism, Hashis, Graves, et cetera, et cetera. So I would suggest we would start with blood work to ensure that you are not living with something other than just hypothyroidism. Synthroid is a good product for some diagnoses, but it's not a great product for others. So if you in particular have Hashimoto's thyroiditis or you have no thyroid like myself, we would tend to prescribe something called desiccated thyroid or natural thyroid. And that may be another option for you. And what happens when women go through perimenopause is that thyroid hormone and your adrenal hormones are all part of the same feedback loop. So if your estrogen's out of whack, it's going to affect your progesterone, it's going to affect your thyroid, it's going to affect your adrenals. It's all part of the same feedback loop. So certainly it's a time when women will experience not just one symptom, it will potentially lead into other things need to be shifted and adjusted. So reach out to your provider first, and then if you're not able to get some information, then reach out to one of us.
Awesome. Okay, great. I keep scrolling down. There's just more questions. This is awesome. So next, what would you recommend for women who have a history of blood clots? Can they use HRT at all?
So definitely women who have clots, we have to be a little bit careful when we use hormone replacement therapies. So personally, I would not give oral estradiol to a woman who's had blood clots, but I would use topical, so that compounded creams or those types of things, and we would monitor very, very closely. We would absolutely want to focus on lifestyle interventions with this patient as well. But no, HRT is still available to that patient. We just need to modify it to them. And I don't know if Susan has anything else to add to that. Okay, awesome.
Okay, great, thank you. Next question is, I had a hysterectomy, still have my ovaries, and I'm on estrogen. Should I be on progesterone too?
I'm so sorry. I was reading one of the other ones. Is this the one that I had a hysterectomy and still have my ovaries and on estrogen? Okay. So this is an interesting question because I've come across some very different opinions. So I'm going to tell you my opinion and based on my knowledge. Absolutely, you should be on progesterone. Estrogen doesn't only just affect your uterus, it also affects your breasts. As that one slide showed, that estrogen does this to your breasts and progesterone does this. They balance each other. So if you're on estrogen only and it's not opposed by progesterone, you're actually putting yourself at risk as far as your breast health goes. The other thing is, why would you not be on progesterone? It's like the wonder hormone. It's a life-changing hormone. It helps with sleep, it helps with mood, it helps with, balancing your estrogen that you're on. It's so, so important. So yes, you should be on progesterone for your health, but also for your quality of life. I love progesterone.
Really? I'm just kidding. Okay. 2 more questions. So I am 52 and using progesterone for the past 4 years. When I had to see my gyno about an issue, he was very unhappy about the hormone therapy, told me my hormones were fine and I should not be taking it. The benefits I get from it are so good. Instantly changed my sleep issues. Why are some physicians opposed?
So we actually find that a lot. And I believe it's because the physicians are not trained in HRT or they don't understand the benefits. They're also maybe not seeing it from the patient's perspective that it's really helping with their quality of life. So, I mean, definitely if you look at the blood work, the hormones might be normal, but the patient is still symptomatic. And we definitely need to treat them. So I just think it's education, and a lot of physicians are not educated on the benefits.
Yeah, I mean, definitely. Just from that video, I mean, that was a GP and he said, I don't know what menopause is. You're fine, like.
Especially from a male's perspective, right?
Yeah. Okay, next question is regarding weight gain related to perimenopause along with thyroid issues. How to help differentiate between which is which?
Yes, well, blood work is key. Certainly, if you haven't had blood work done by someone who is a thyroid understander, someone who really understands thyroid, it's not adequate just to look at your TSH, which is what 9 times out of 10 you'll get done. So we would start with a much more comprehensive thyroid assessment. Make sure that that's optimized, and then at the same time look at what other hormones could be contributing to the changes that you're experiencing. I will tell you that weight gain related to menopause, perimenopause, and menopause is extremely common. It's very, very common. Perimenopausally, it's that volatility of the estrogen. And so you could wake up one day feeling like you gained 5 pounds, and a few days later you've lost 7. It's that quick. And when you're post-menopause or getting close to going through menopause, the weight gain on your abdomen is also very common. And it's all a part of that estrogen. So it's hard to differentiate. We would want to optimize everything. And if you're ready for estrogen, then certainly that will also help with weight changes. And of course, we would do, review lifestyle stuff and diet and all that sort of thing as well.
Fantastic. Okay, good job at answering all the questions, guys. That was, I think, maybe the most questions we've ever gotten in a talk. So that was awesome, super informative. I cannot thank you both. Just from the bottom of my heart, it was amazing. I learned so much. And I think everyone did. I'm sure there will be lots more questions coming your way. So I'm glad everyone knows how to connect with both of you now. I also would like to give a big thanks again to Alberta Blue Cross. We could not host these sessions without your support. So thank you so much for your continued support. And I just want to let everyone know who's on the call. We would love for you to support the Lois Hole Women's Society. It is a great society. Amazing initiatives happen with this group of women. And we really want to stand behind our women's only hospital and support them in any way we can. So if you are interested in becoming a member and supporting the hospital, you can reach out to myself or Paula or Brianna, who introduced our speakers, any of us, or you can go to our website, which is lhhwomensociety.com, and make a donation or become a monthly member. I want to let you guys know that our next lecture is on May 20th. We will be joined by Renee Leclerc and Rachel Glover, and they're going to be talking about how to make health conversations, so important health conversations with teens and children comfortable. So if there's any parents that are there, or aunts or siblings, we've all had some awkward conversations with some younger ones. So I'm really looking forward to that talk. So stay tuned, guys, for registration and further information on details for that one. Have a great evening, guys.
Thank you, Crystal.